Good morning and welcome to June Grand Rounds. And we have a special event today with the research projects being presented by the Postdoctoral Fellows. I'm Carol Rockhill. Sorry, I haven't been introducing myself. I'm one of the Grand Rounds organizers. We acknowledge that we're on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe, but also acknowledge that this acknowledgement itself does not take the place of authentic relationships with Indigenous communities and is just one way to honor the land and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of free enslaved labor by Black people. We honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. And we affirm our commitment to be aware of our own privilege and oppression and how they play a role in the lives of patients, families, and employees, and strive to be anti-racist and to improve our care of those who have less privilege. We also want to celebrate that June is LGBTQ Pride Month, and I think there were great events yesterday, both in Seattle and at Olympia at the state capitol, rolling out LGBTQ flags. And I also want to point out that Juneteenth, which commemorates the day in 1865 when the last remaining enslaved people learned that slavery had already been abolished a couple years before. So looking forward to that holiday. I do want to announce also that this is our last Grand Rounds of the series, and that I want to really thank Mendy Manharas, who has been my co-organizer the last couple of years, and she is still helping us, but is going to step away from that role, and to announce that Michelle Kuhn is going to take her place. I also want to thank Catherine Sweeten, who has been our lead administrative support and has been extremely helpful. I do want to also let people know this meeting right now is going to go until 9:30 instead of 9:20 because of having all of the speakers that we have today, and that then the faculty meeting will start late at 9:45. And also let you know that from 12 to 1, Sarah Walker is doing Grand Rounds for the University of Washington program. So tune into that if you can. And now I will pass to Joy Kawamura, who is the director of the postdoctoral program, so she can announce our speakers.
Thank you, Carol. Good morning and welcome again to our June Grand Rounds. This morning, I have the pleasure of introducing 7 of our child and adolescent psychology postdoctoral fellows who are in their final stage of training to become child clinical psychologists and neuropsychologists, having already earned their doctorate degrees and completed their pre-doctoral internship training. Our fellows have specialized in a variety of different areas, and this morning they will be speaking about clinical and research projects that they have been working on for the past year. In the interest of time, we're going to hold questions until all 7 of our fellows have presented. For those of you who are joining from Zoom, please feel free to type your questions in the chat. I think we're monitoring that, and we'll hopefully have time at the end to have folks answer those questions. I also want to recognize the other folks that are involved with training, Karen Barris, who is the training director on the Autism Center side, and all the supervisors, some of them who are here this morning, who have mentored, supervised, guided our postdoctoral fellows, and all the trainees in our training program this year. Okay, please join me in welcoming all of our postdoctoral fellows, but we'll be starting this morning with Dr. Alana McVeigh.
Good morning. Thank you all so much for being here. I am excited to speak with you all today about my work, which is focused on redesigning dialectical behavior therapy for autistic young adults. So first of all, just want to indicate that I have no conflicts of interest to disclose. And before I jump in, I want to provide a note on language. So in talking about autism, many of us were likely trained to speak about autism using person-first language. So person with autism, child with autism, adult with autism. And in recent years, autistic self-advocates have indicated a preference for the use of identity-first language or autistic person. And I think the autism researcher, Stephen Kapp, really captures this in a lovely way where he describes that he wants to celebrate autism as an inseparable aspect of his identity. So throughout my presentation today, you will hear me use primarily identity-first language. You may also hear me use the second most preferred term, which is person on the autism spectrum. So as we all know, autism is really at the intersection of differences in social communication in combination with repetitive behaviors and or interests. The prevalence of autism is on the rise. So the current CDC estimate is 1 in 36 8-year-old children in the United States. And you may or may not already know that suicidality is a very common concern among autistic adults. So as many as 72% of autistic adults report suicidal thoughts and behavior, and approximately half engage in non-suicidal self-injury. One treatment, dialectical behavior therapy, which was created by Dr. Marsha Linehan, is a third wave behavioral therapy that really balances acceptance and change and was developed specifically to address chronic suicidal thoughts and behaviors. This treatment, as you probably know, has a very strong evidence base. DBT may be well suited for autistic young adults for a variety of reasons. First, the treatment is structured and flexible. First of all, the treatment itself has a great deal of structure to it. So in terms of the different modes of treatment, which I'll talk about in just a moment, they provide a nice framework that could be useful for autistic young adults. And then within each of those modes, there's also some nice structure. So for instance, in individual therapy, the sessions are structured in a way that's predictable. The treatment is also flexible in terms of its delivery. So clinicians have a lot of leeway in terms of how they might choose to deliver the treatment. There are few studies, however, that have tested DBT for autistic young adults. So only 2 that I know of. There is a third study that is a protocol paper of a randomized controlled trial out of Europe, but those data are not yet available. None of these studies, however, have used systematic or iterative approaches in the way that they have redesigned DBT for autistic adults. So each of these studies has made some adjustments to how they deliver the intervention, but they haven't done so in a systematic way. And they also have not involved key stakeholders. So they haven't involved autistic adults as research partners or key stakeholders in the studies. So to tell you a little bit about those comprehensive DBT modes, so in that full model DBT program, we have individual therapy, which is weekly, typically an hour, outpatient setting. There's also a skills training group. Pardon me, this is usually about 2 hours per week where the patients would learn the DBT skills. The third mode is phone coaching. So this is where the individual therapist is available to the patients in between their sessions for short, focused skills coaching in the moment. There's also consultation team for the DBT clinicians. So this is really thought of as essentially therapy for the therapist to maintain their skill and motivation in delivering DBT. And then last is collaboration with ancillary treatment providers. And this is actually pretty broad in DBT and includes both collaboration with other providers like psychiatrists, for instance, if the psychiatrist is not the DBT therapist, but also includes potentially intervening at the environmental level. So collaborating with other family members like parents or siblings even sometimes. So I am using the Discover, Design, Build, Test framework developed by Dr. Lyon and colleagues, which uses implementation science and human-centered design. And this is really a framework that ensures usability, feasibility, appropriateness of the redesigned intervention with maintaining the client-facing efficacy, so reducing that suicidality and self-harm, pardon me, for autistic adults. And this is really to be delivered in the community. So focusing on how we can redesign the intervention for delivery in the community by DBT clinicians who are already doing DBT. So I'm excited to share with you some preliminary findings from the first phase of this study, so the Discover phase. So in the first part of the Discover phase, I conducted qualitative interviews focused on understanding the determinants, so the barriers and facilitators for autistic adults in accessing evidence-based treatment for suicidality in the community with a focus on DBT. So I interviewed 10 autistic adults, 10 DBT clinicians, and 5 DBT clinic leaders. So I'll share some of those emerging findings with you. So we're really finding some barriers and facilitators across 3 different levels. So first is at the clinic level. So one example of a barrier for autistic adults in receiving DBT in clinics in the community has to do with clinic policy. So some clinics will not accept autistic adults into their programs right from the get-go. So that certainly is a big barrier. Other opportunities, though, things that might be a facilitator at the clinic level, are some DBT clinics accept a wide range of insurances. And so that can be a facilitator for some autistic adults in receiving DBT. At the clinician level, autism knowledge is a big piece that seems to either serve as a barrier or a facilitator. So clinicians who have training or experience with autism, that can serve as a facilitator. However, there's a caveat to that, and autistic adults have really spoken about how clinicians who have lived experience understanding of autism. So for instance, autistic adults who spoke about having a clinician who had a child on the autism spectrum, for instance, they felt more connected and able to work through treatment than a clinician who maybe had only received some training in autism through the medical model lens. And then at the client level, one of the things that the DBT clinicians have spoken about has to do with cognitive style. So again, this can kind of serve as a barrier or a facilitator, depending on the particular circumstances. So on the barrier side of things, clinicians described autistic clients seem to have a particular cognitive style that can be challenging. So in particular, some rigidity or black and white thinking. And these are DBT clinicians who are used to working with patients with borderline personality disorder, which is known for, very black and white thinking. But there seems to be a different cognitive style or rigidity there that clinicians have noticed and spoken about. Also, on the facilitator side, some clinicians describe autistic adults really diving into learning DBT. So one clinician described that a client sought to learn DBT like a language and really took it on and dove into it. And so in that way, it was a facilitator. I also just briefly want to describe, how some of these aspects at these various levels can be dynamic, right? Or have to do with the match. So thinking about clinician and client match in terms of that cognitive style. So really thinking about what's known as the double empathy problem, right? So clinicians who may themselves be neurotypical interacting with autistic people, and there just may be a neurotype mismatch that may lead to some of these barriers that we're seeing. Through these interviews, I've also identified some preliminary targets for redesign. And as you saw from that Discover, Design, Build, Test framework, I'm working through each of these steps to really find the targets, and then we'll iteratively redesign them. So this is kind of early stages, but thinking about some of those preliminary targets. So in general, many of the components of DBT do seem to be working well for these autistic adults, but there are certain areas that seem like they might be kind of prime for redesigning. And so in individual therapy, I already spoke a little bit about kind of the client-clinician match. One of the suggestions that's been put forward is sort of a mechanism for individual therapy where clinicians and clients can speak about the client's experience of autism, not for the client to teach the clinician about autism in general, but just to facilitate a conversation about the client's own experience of autism. Within skills training group, one of the recommendations is really being able to make the somewhat complex handouts from the adult materials available more in plain language or use of visuals, those kinds of things to facilitate the learning of DBT skills. In terms of phone coaching, the method of phone coaching is typically a phone call between the client and the clinician. Some clinicians will engage in phone coaching with their clients via text message, but not all clinicians are willing to do this. And that seems like something that could be helpful for autistic adults, especially when they're experiencing dysregulation. In terms of consultation team, clinicians have indicated that they would really like to have somebody embedded on their consultation team who has experience and expertise in autism, and in particular, perhaps someone who has experiential expertise as well, so lived experience. And then in terms of ancillary treatment, this is a really interesting mechanism in thinking about potentially adapting for autistic adults. Typically in DBT, there is a consultation to the patient agreement where clinicians do not intervene on the environment on behalf of their clients, but rather they consult to their clients who then intervene. And when working with autistic adults, there may be certain circumstances where clinicians may be more likely to intervene directly on the environment for their clients or patients, and times when autistic adults would want this. And autistic adults have spoken about wanting to have a lot of transparency around how that would work for them. All right. And with that, I would just like to acknowledge my funding sources, the Autism Intervention Network on Physical Health, the International Society for the Improvement and Teaching of Dialectical Behavior Therapy. I would also like to give my thanks to my project mentor, Dr. Jill Locke, and my career mentor on this project, Dr. Gary Stobie. I also want to extend my gratitude to my project coordinator, collaborators, consultants, and volunteers on the project, and then, of course, my participants. I will provide my funding statement here, and we'll take questions at the end. Thank you. And I would like to now introduce Dr. Angela Dahia.
So I'm going to be talking about my dissertation on providing telehealth support for caregivers of autistic children using a mobile app. So first, I'll just do a brief overview of the literature in the background, and I'll go into details of the study, and then I'll go into results and the future directions of the research. So kind of just thinking about a brief background with parent training in autism. We know that autistic children often engage in different types of behavior difficulties that include tantrums, aggression, non-compliance, and resistance to change. And a lot of these behaviors do impact parents and family functioning, especially in the area of parenting stress. And so there's a lot of different evidence-based principles that are well known to support parents with managing some of these behaviors, such as using a functional behavior assessment, as well as prevention and reinforcement strategies. So with that in mind, especially during the pandemic, and even before then, there's been a lot of research on telehealth parent training, such as Ruby, which is done here at Seattle Children's, and See Hope, that have shown significant improvements in parent and child outcomes. And a lot of these outcomes have been shown to be comparable to in-person treatment and have shown a lot of parent satisfaction following that treatment. So kind of with this in mind, I wanted to look more at telehealth for my dissertation and focus on using a mobile app to develop some of these evidence-based treatments to support parents of autistic children. So I was able to get a grant to partner with a company called Thrust Interactive, and they have an app called the Trex app, which is a behavior change platform that supports users in changing different parts of their lifestyles. They include videos, different strategies, activities that they can do, and as well as reinforcement. And so I kind of worked with this company to use content that we know from these evidence-based principles for autistic children and input some of this content into an app. And so they're kind of doing Trex, which is like an activity every day over the course of 4 weeks. And so it's broken down based off those principles. So this is kind of an example of what that looks like. So for example, for the ABCs of behavior, learning how to do a functional behavior assessments, the parents will start by watching a video on how to chart some of that information and gather information about their child's behaviors. And then they'll be asked a couple of questions to just assess their knowledge, and then they'll be done for the day. So really just a brief, quick activity for them to do each day, just to kind of get some knowledge and learn how to apply that to their child's behaviors. So going into the study, so I had two aims for this project. One was to look at feasibility, and then two was to look at the preliminary efficacy of this program. So I looked at whether TREX as an enhancement to telehealth consultation was more beneficial than having that telehealth consultation with the addition of just mobile resources through the app. And so for today, I'll just be focusing on AIM-2 in the interest of time. So for my participants, I was at Virginia Tech, so most of my parents were from the Virginia area because it was a telehealth program. I was able to recruit from other states like California and Texas, but majority of them were from Virginia. And so I had 26 participants, 14 of the parents were in the telehealth group and 12 were in the control group. And so all these children had to have an autism diagnosis to be in the study. They had access to some sort of smartphone device, whether it's an Android or Apple device. And there was some sort of target problem behavior that the parents had identified that they wanted to focus on. And so there's 3 different time points. So first, they did initial screening just to assess just their interest, and did an intake to confirm the diagnosis and language ability of their child, and to identify what target problem behavior they wanted to focus on. And then they had a one-on-one telehealth consultation over Zoom, which took about an hour and a half to 2 hours, that really reviewed in detail the evidence-based practices and kind of went into what the child's behavior problem that they wanted to focus on was, and how they can use these evidence-based strategies to help them out. And then they were either randomized to 4 weeks of telehealth support using the app, or they also had 4 weeks of telehealth support using the app, but they just had access to the mobile resources. So that was just the videos and the outline of the evidence-based strategies that they had access to. So the outcomes that I looked at, in addition to feasibility metrics for the parents, I wanted to focus on parenting stress. Like I mentioned, that's a big thing that's impacted by these behaviors, as well as parent competence of using these strategies, and their just overall knowledge of the strategies and applying those. And then in terms of child outcomes, I just wanted to look at disruptive behaviors and the frequency of those behaviors. And so my plan for the preliminary efficacy aim for the feasibility, I did look at the different metrics, but I wanted to look at the group differences at baseline to see if there's any differences between the two groups, and also examine those outcome variables from pre to post TREX in both of those groups. So at baseline, there actually were no significant differences amongst those different screening measures and the parent and child outcomes, with the exception of the parenting stress index. And so you see that there were actually significantly lower stress in the control group versus the telehealth group, but there wasn't any other differences across both of these groups. And then when looking at outcomes, surprisingly, it was really great to see that the telehealth group did actually have significant improvements across all of the different measures. So the parenting stress index, parent training knowledge questionnaire, sense of competency, and the child behavior problems. And so there was a significant increase across all these different areas. And again, they felt, parents just expressed in general, they felt more competent in learning how to implement these different management strategies for whatever behavior problem they wanted to focus on. And in the control group, there was there wasn't a significant improvement other than in the parent training knowledge questionnaire, but there was a trend towards improvement overall in all these different measures for parenting stress and sense of competency and the behavior problems. So it was minimal, but it still was observed overall. And again, parents expressed satisfaction in even just having access to the resources and having access to, knowing what these evidence-based strategies were. So like I mentioned, we did see few significant group differences at baseline, and we saw really great improvements in the telehealth group across all these different outcomes. And there still was a trend towards improvement in the control group with a significant increase in parent knowledge. And it's, I think, just a piece to think about is the fact that both of these groups were actually exposed to these evidence-based principles, whether it be through the consultation and discussing them with them, or the TREX app itself and having more access to being able to apply it, or even, again, those mobile resources. So they still had that exposure, which I think impacted some of these results. So just thinking about future directions of this research, I think this gives some evidence that supplementing treatment with the mobile app has that potential to support caregiver and child outcomes, and it can broaden access to services for those who don't have the ability to come in person to see a therapist and are living in maybe more remote areas. And I think ideas for just developing the app is personalizing it depending on the behavior problem, having more just like weekly check-ins with the caregivers to see how things are going, because they kind of were given the app and they had 4 weeks to complete it, and then we checked in at the end. So some of them kind of expressed interest in having a little bit more of a check-in. Also embedding videos that are made in-house. So we use YouTube links that we embedded in the app. And so having your own videos would be a little bit easier. And also adapting the platform for children with other diagnoses or even just trans diagnostics. We know autism often overlaps with other diagnoses like anxiety and ADHD. And so the hope is that similar platforms like this can increase accessibility for families who are unable to meet with their providers, but still require some sort of support. All right, and I'd like to thank the Virginia Tech Cross-Destination Area Institute Grant and Thrust Interactive for supporting this project, as well as my lab members from my lab at Virginia Tech and my advisor, Dr. Angela Scarpa. All right, thank you. I'll next introduce Dr. Anthony Osuno.
Good morning, everyone. I'm Anthony Osuna, and I'm going to talk to you about Selfie, an internet safety intervention for autistic adults. So about a month ago, the APA released a health advisory acknowledging that social media is a public health concern for adolescents. You all work with kids, you know some kids, I'm sure this isn't a surprise. One of the recommendations, and I really recommend you all read it because it's pretty exhaustive, but one of the recommendations is that adolescents should receive social media literacy training to develop the skills necessary for safe and effective internet use. We make kids go to the DMV and do driving school before they drive, but we don't make them get any training in social media before we put them on the internet. I've been lucky to have people who do autism research present right before me, so I won't go too much into it, but we know that autism is characterized by impairments in social communication face-to-face, but very little is known about how they socialize over the internet. And that's where a lot of people are actually socializing, communicating these days. Many autistic people report that computer-mediated communication is actually preferable. And if you think about how challenging face-to-face communication can be, it makes a lot of sense. Within online social communication, it's flexible. You don't have to read as many social cues. And if someone messages you, you can reply tomorrow if you want to. Whereas in face-to-face, there's a lot of pressure to respond immediately and in the most appropriate way. And so autistic people say that, the internet allows you to have more comprehension and control over interactions. And so I think this is a really important place that we support this population. And autistic people are reporting many benefits to online socialization. Autistic adults tend to be more isolated than their non-autistic peers. And autistic people are saying, well, we have better friendship quality and greater quality of life because we are socializing on the internet. That being said, we know the internet is full of dangers and challenges. And so autistic people also report having more anxiety, harassment, and cyberbullying. There are many interventions that have been used to address face-to-face socialization. These tend to be called social skills interventions. However, no intervention explicitly targets online socialization. And this is where Selfie comes in. Selfie stands for Socialization, Education, and Learning for the Internet. You can just call it Selfie because it sounds a lot cooler. The Selfie intervention was something that I developed as part of my research in graduate school. It's a 9-week intervention. Each session's about an hour. It's in group format and it was delivered over telehealth. And the ultimate goal is to target safe and effective social media use. There are several evidence-based practices included in it, including lessons, experiential learning through practice activities, and use of peer mentors. It follows this format in the top, but what you'll just really notice is that there's a video discussion, a topic discussion, and opportunities for practice. This is the 8-week curriculum. I said it's 9 weeks, but the 9th week is a graduation. And it the curriculum progresses from most basic skills to more challenging skills. And this curriculum was put together based on the literature that identified, well, these are the skills that you should use in order to have pro-social relationships online. And this is what you shouldn't do in order to avoid conflict online. And so maybe talking about politics has been noted in the literature of maybe you shouldn't talk too much about that, but maybe you should wish your friends happy birthday. Also, you should have a profile picture that looks like you. So for the study, I did a randomized controlled trial where participants were either randomized into the active treatment condition, the selfie program, or a waitlist control condition. This is a new intervention, and so the primary goals were actually feasibility and acceptability, but we also did explore treatment outcomes to just explore preliminary efficacy. We had 25 autistic adult participants. Expected male to female ratio. They were all young adults and didn't have an intellectual disability. And one of the kind of important pieces here is that they had to use Facebook. I'll explain why in a sec. So for feasibility, again, it's like, can we do it? Attendance, fidelity, that type of stuff. And then acceptance-wise, we looked at attrition from the study, and then we also got feedback from participants and peer mentors who were involved in the intervention. So assessing outcomes in a social media skills internet safety intervention was kind of tricky. We're not really familiar with how to evaluate social media behavior. And so we tested out some unique approaches. One is we wanted to look at anxiety because anxiety has been demonstrated to moderate the relationship between internet use and friendship quality in autistic adolescents. But we wanted to choose a measure that was sensitive to the anxiety that someone might feel online. Because if you're familiar with the Beck's anxiety inventory, a lot of it's like physiological symptoms, and we wanted to get at social media anxiety. And so there is this scale out there. It breaks down into two subscales, which is social media utility. And it's not how often you're using it, but how much benefit you feel like it's giving you. And then the anxiety piece is like, I worry about my replies to people on the internet. It's a really brief scale though, 10 items. But then we also wanted to see whether or not there was a behavioral difference. I come from a behavioral background in autism. And so we were like, well, who cares? Not who cares, but like in addition to what they say, I wonder if it changes how they're actually behaving. And that tends to be an area of interest in social skills interventions. And so to do this, we had to get a little creative. And so what we did was we looked at Facebook activity. And the reason why we did Facebook is because Facebook is the only one that's creepy enough to give you too much information. And so if you could try this on yourself later, you can go to facebook.com/DYI, which stands for download your information. And you can identify a time frame that you want to get your activity log. And this will tell you how many likes, comments, posts, who you friend request, all of your activity. It's pretty creepy. And so what we wanted to look at was actually the frequency of socially relevant behavior, like likes, comments, and posts, because that gives opportunities for social engagement. But we also wanted to see if there was a qualitative difference in how they were engaging online. And so we did that through this thing called improvement ratings, which we developed for the purpose of the study. We recruited 12 research assistants. Half of them were autistic, half of them were not, half male, half female. We wanted to make sure it wasn't just neurotypical college girls reading a bunch of autistic people. We developed a scale where we presented the Facebook activity before and after the intervention. We put the frequencies of certain behaviors. We did cap it at 10 because we didn't want it to be all about how frequently you were engaging, but really about the quality. And so what you'll see here is that one participant had no post, no activity at the beginning, and at the end, they were posting beautiful pictures of their art. And we really reduced it to one question of, did this person's Facebook activity improve? And again, use your own subjective approach on how you want to evaluate that. But really, we just wanted to see who improved, who didn't improve from the perspective of these autistic and non-autistic college students. Feasibility-wise, we recruited, there was about 65 people who expressed interest in the study, 25 enrolled, good attendance, good fidelity of treatment delivery. We shared our screen during the intervention, so it makes sense that we didn't forget anything. 7 folks dropped from the study. That included people on the wait list. And we got a lot of positive feedback. And it wasn't really about, well, this is the greatest thing ever, but really, what are some areas that we can improve on? And what are some areas that we should make sure we emphasize moving forward? One thing we wanted to, again, look at was whether or not there was a difference in the improvement rate or the increase of frequency between the treatment and the waitlist control condition. Those who had an increase of likes or posts or improvement from baseline to exit were demonstrated as, or were classified as responders. And what you'll see is there's varying degrees of difference here, but really the most important thing is that the selfie group had more participants who demonstrated improvement, and the waitlist control did not see very much improvement. There was no significant differences in social media utility and anxiety. All of the participants reported increased utility and decreased anxiety. This was during the pandemic. I think it was a really interesting time to be on the internet. So I think this is something we want to explore a little further later. There are some limitations. This was autistic adults. I started off with the APA advisory about this really being a need for adolescents. To be honest, for your dissertation, it's a little easier to do some research with adults. Eventually, I do want to bring this down to adolescents, and we want to make it more platform agnostic to where it's not just Facebook that is informing the intervention. And I didn't ask any stakeholders about their input, so that's definitely something we want to do. But this is a very important first step in supporting vulnerable populations on the internet. This is, again, the first step, but we have a lot of more work to do. So I'm really excited to get engaged in this work even further. These are cute pictures of my dogs. I don't have time for questions, but thanks, everyone. All right, and then I will introduce Dr. Galka.
Hi, everyone. My name is Elizabeth, and I am the postdoc fellow with the Neuropsychology Consult Service, along with my supervisor, Skylar Leonard. I'm in my first year of 2 here at Seattle Children's, and I'm excited to talk about the role of neuropsychology in a pediatric hospital setting. So my goal for this brief presentation is to have all of you walk away with an understanding of what neuropsychology is, understand the goals and limitations of a neuropsych evaluation, and explain the role of neuropsychology within a multidisciplinary clinic team here, mainly through the example of the brain tumor clinic. I will also give a brief overview of the research that our team is pursuing to better address our integration on that team. So first, what exactly is neuropsychology? So brief history lesson, before the 1970s, the brain was a black box. There was no real understanding of what was going on inside of the brain until after people had died. After the 1970s, with the use of X-rays and EEG, it helped to identify more information about the brain, skull structure, and electrical activity at the surface layer of the brain. In the 1970s, neuropsychology was focused on areas of deficit in brain functioning and identifying where lesions were present in the brain. For example, if a neuropsychologist completed an evaluation, a comprehensive assessment of a patient with epilepsy and found relative right-handed weakness, language deficits, and impaired verbal memory, they would conclude the seizure focus was in the left frontotemporal area. This is in the time in which early professionals like Paul Broca, who studied how speech is understood and produced, Carl Wernicke attributed brain function to different brain regions, and Carl Lashley introduced the idea of brain plasticity, became integral in the development of the present-day foundational principles of neuropsychology. These early foundations of neuropsychology led to what we currently understand as the present day definition. So the American Psychological Association's dictionary has this definition of neuropsychology. So now that that's incredibly clear, neuropsychology is the understanding of the impact of medical history on all areas of functioning. For example, if a child has a traumatic brain injury, a neuropsychologist works to identify what impact this injury has had on their overall development and what impact it has on their future cognitive, academic, social, and behavioral growth, and creating a plan that meets them where they're at. Other times, neuropsychology takes on a neurodevelopmental nature. Say, for example, a child with a genetic disorder. We want to identify the effect of the disorder on that child's development and addressing what supports they will need in the future. Our role is also helpful to assist with localization of brain function and dysfunction, especially in the context of epilepsy surgery, to help determine what skills or abilities may be lost if surgery for these patients is pursued. Sometimes, though, it's easier to identify what something is by identifying what it is not. So neuropsych evaluation is not a brain scan like an MRI or medical assessment like an EEG. Those are usually ordered by a neurologist, and while we use that information to help shed some clarity on a particular patient's medical history or diagnosis, we do not order those ourselves. A neuropsych evaluation is also not counseling. We take a multimodal approach to our evaluation that includes gathering information by multiple sources through interviews, but we are screening for areas of concern, not meeting for therapy. Lastly, neuropsychology evaluations are not psychoeducational in nature. We are not gathering progress monitoring data or qualifying children for an individualized education program or an IEP. That is really the role of a school psychologist who can better understand the progression of difficulties in academic areas. While sometimes we recommend a patient be evaluated for an IEP or a 504 plan, the goal of our evaluation is to shed light on the impact of the medical history on a patient's functioning, and sometimes that information is not available or understood by school-based clinicians, and that's where we're most helpful. So what exactly is a neuropsych evaluation? We focus on the impact of medical concerns like brain tumors, leukemia, epilepsy on brain-related processes. We help patients understand any effects of their overall functioning because of treatments such as surgery, chemotherapy, or radiation, as well as identify how complications like anoxic events or hydrocephalus have on their overall brain functioning. In the evaluation, we identify areas of strength that parents and families and even teachers can build on, and if there are any areas requiring additional support to inform further treatment and plan for school. We also highlight what recommendations or referrals, such as mental health, speech therapy, OT, PT, and so on, may be helpful. Our evaluation is comprehensive and multimodal. We interview the family members, the patient, and teachers where applicable. Sometimes we need additional information from the referring provider or teams, and sometimes we need information from the patient's school-based team. We use questionnaires and assessments that look at all of these different areas listed here, like cognitive ability, both nonverbal and verbal reasoning, a brief screening of academics like math and reading. Behavioral observations are just as critical as the results of the assessment because it gives us information about their day-to-day that we may not be able to see through test results. Because we work in a one-to-one setting with patients, gathering information about their social emotional well-being, executive functioning, and adaptive skills through questionnaires from parents and sometimes teachers, it is helpful to give us a broader perspective of who the patient is. Now that we have a broad view of neuropsychology in our evaluation model, I would like to talk about our work within the multidisciplinary clinic team. We are part of a few different multidisciplinary teams here at Seattle Children's, but for the purposes of today's conversation, I will talk about the brain tumor clinic team. The brain tumor team is comprised of many professionals, including neuro-oncologists, all of the professionals listed here, as well as so many more like rehabilitation, child life, endocrinologists, speech pathologists. All of these individuals work together to meet the needs of the patients and have a working understanding of how to support our patients. While at this point you've developed an understanding of what neuropsychology is and why it can be helpful, our role on this team is actually supported by the standards of care from the Children's Oncology Group that identified the barriers for children who have or have had a brain tumor. Focusing on neuropsychologists, our work in the multidisciplinary clinic serves several purposes, including screening for concerns and needs for comprehensive evaluation, monitoring progress over time, providing information to families, triaging patient needs, and providing recommendations. Because we work with patients at various stages of treatment or recovery, our information ranges from how to request a 504 plan so that a child undergoing chemotherapy can attend school without being penalized for missing due to hospital appointments or illness, to now that the patient has finished their treatment, what difficulties are they experiencing at school, at home, or other places? Sometimes we are referring patients for an evaluation to understand what, if any, effects radiation, surgery, or chemotherapy has had on their overall functioning 1 year post, and then evaluating in 4 years since the patient had had time to reintegrate in school, their community, and life after treatment. Lastly, sometimes our role is helping connect families to resources like developmental disability administration or connecting them to other specialties like social work or psychiatry for mental health needs. Along with Skylar and support from other professionals in the brain tumor team, we're currently in the early stages of wanting to research, quantify, and analyze the data available to understand how many of the patients who are currently being monitored by the brain tumor team have had some neuropsych intervention, meaning have they had a consult with us, have they been referred, have they had an evaluation? Previous studies have focused on identifying barriers to neuropsych care. However, we want to review access to neuropsych care for active patients by identifying the amount of time needed for initial evaluation, consultation, and identified school-based resources like a 504 IEP. We would like to analyze the information to understand what cultural, like non-English speaking families, socioeconomic, like lack of resources to travel to Seattle Children's, for an evaluation, or systemic barriers like insurance denials, not being referred for an eval, being lost in the wait list, our patients face in accessing what can be a very informative and helpful evaluation. There's also a lack of understanding regarding the cultural, socioeconomic, and systemic challenges that act as barriers for neuropsych care from patients from the perspective of different professionals in a multidisciplinary clinic team. I hope this information today helped to identify what neuropsych is and what our role is in the context of Seattle Children's. And now I would like to introduce Dr. Lupita Santillan to give her presentation.
Hello, today I will be talking about parent-focused treatments to promote early childhood development. These are two studies that I have been part of this year at Seattle Children's. So the first one is the BOOST study, which is the book Sharing for Toddlers with Clefts. A little bit about this study. So children with cleft palates are at risk for poor language outcomes, and there are currently no published interventions regarding published studies regarding interventions for these challenges. And so in the BOOST study, we teach parents how to use dialogic reading strategies to support language development in the home setting. We're also using novel strategies such as remote and telehealth work to reach geographically dispersed families across the US, as well as Spanish-speaking and bilingual families. And so a little bit about dialogic reading. Dialogic reading focuses on teaching parents how to help kids be active participants while they're reading, while they're doing shared reading. And so we try to stray away from a more instructional approach to like getting through the book or reading the whole book, to making helping parents help their kids be active participants and interact while they're reading, this is verbally or non-verbally, but really increase the communication and the participation that happens during reading time. So about the study process, so the first part is we teach caregivers these strategies. We do this through 4 intervention visits that we have. In these 4 intervention visits, we also have families submit videos of them reading with their child the week before we meet, so that the clinician that's delivering the intervention can provide some feedback on the great things that the parents are doing and also some areas of improvement. So every week, parents submit a video, upload a video of them reading with their child so that we can provide that feedback. These videos are also the videos that the research study team is going to use to analyze the use of these dialogic reading strategies with parents. And so first we deliver the intervention, we provide parents with that feedback, and then the goal is to code these videos to be able to see how much caregivers are using these dialogic reading strategies while engaging in shared reading with the child. So the next steps for this study. So currently we are establishing reliability with the research team, coding these videos. So being able to identify when the parents are using these strategies and when the parents are engaging and helping kids be active participants while they're reading. At the same time, the research team is also analyzing the clinician fidelity of delivering this intervention, and so coding the delivery of the intervention. The goal for this study is to conduct a randomized control trial that will start hopefully in September. Now I'm going to switch gears to another study that I've been able to be a part of that focuses on using a task shifting model to increase access to evidence-based anxiety treatments in early childhood, specifically with Latino preschool children. So a little background about this. So anxiety interventions as a whole are limited and often inaccessible, specifically during the early childhood age range. And there is a service gap specifically for linguistically diverse and culturally diverse families. And so one of the models that has been used to support accessibility and increase accessibility is a task shifting model. And so a task shifting model focuses on training non-mental health care providers to be able to deliver brief interventions and brief mental health interventions. And so the primary objective of what I'm focusing in at the moment is to understand the acceptability of a task shifting model using promotoras. And promotoras are the individuals that we are training to provide this brief intervention. And so we want to understand the acceptability of using promotoras for the delivery of an anxiety intervention for early childhood Spanish-speaking parents. And so what we did initially was we had 6 parents who had previously participated in an anxiety group here at the Seattle Children's Trauma Clinic. They participated in the promotora training. And after participating in the promotora training, they participated in a qualitative interview post-training. After this, the research team developed a code book, and through this code book, we were able to independently code these qualitative interviews. And so the final product of this was to create that this would be used as a small pilot, so that then it would be able to be used for the implementation of the rest of the study. So these are some qualitative preliminary themes that we have seen. There's been themes about acceptability to the promotora role and the task shifting models. So there's themes regarding the connection that families will be able to have with these families, that the promotoras will be able to have with these families, given that they've had similar experiences, had similar challenges. We've learned about cultural implications. So promotoras often discuss normalizing seeking mental health services, as well cultural things that we need to take into account as we're thinking about delivering interventions to the Hispanic community and perceptions regarding mental health. Barriers to the promotora role, which often include things like confidentiality, mistrust in the providers, and not feeling comfortable being trained by somebody that doesn't have an extensive training like a psychologist or other mental health therapists. And they also provided recommendations on how to improve our promotora training and how to improve the model and make it more helpful for the promotoras that are going to be trained and for the families that are also going to be participating in the study. So here is, and this is in Spanish because that's how we conducted the qualitative interview. And so I'll do a quick little translation of, we asked questions about what their opinions about the promotora role was. And in this case, this caregiver talked about how she thought it was really interesting and an interesting model specifically for the Hispanic community. Talked about the importance of mental health and early intervention, and also how it's so important to have these interventions be delivered in Spanish so that the families feel comfortable and feel supported when they're participating. They've also talked about what some of the barriers they perceive could be. And in this case, the barriers that they talked about were not feeling very comfortable with the promotora delivering the model, given that they are not psychologists and do not have the training that a psychologist does, and being concerned that the promotoras would only be speaking from their experience rather than from an educational background. So those are things that we take into consideration as we're looking through developing the model and implementing the model with promotoras as part of our intervention. So the next step for this study is to evaluate the feasibility and acceptability of the model. In a sample trial, we've had 20 participants. And we also want to evaluate the promotora fidelity coaching of the intervention with the parents post-trial. We've had 2 groups. We just wrapped our last group. And so that'll allow us to start looking at analyzing the more qualitative information, as well as some self-reports that caregivers provided throughout their participation in the group, and as well as the promotor's experience delivering the intervention. So I just want to take some time to thank the teams that have allowed me to work with them. So Dr. Brent Collette, Dr. Cindy Trevino, the Boost Study team, and also all the members and the promotores of the Latino Preschool Anxiety Study team. And next, I'd like to introduce Dr. Shannon Liebman.
My name is Shannon. I'm going to be talking to you a little bit today about some of the measurement-based care work we are doing in our Disruptive Behavior Crisis Clinic, which is part of our behavior and attention management set of programs. To start off, though, I would love to shout out a few folks that have been really key in this work. Obviously, all the trainees and attending clinicians that have been part of delivering this Disruptive Behavior Crisis Clinic intervention, as well as our colleague James Williamson, who's here with us today, who was really instrumental in not only providing and building our survey structure and using these data to analyze and take a look at what's going on, what our families are reporting to us as they participate in this program. I have no financial interest to disclose from this work. Just a quick background about what we mean when we say measurement-based care. We might be able to define this as a systematic evaluation of patient symptoms and progress, primarily to inform treatment, but can also be used for program evaluation and research. And we also know that there's a strong relationship between robust measurement-based care systems and the positive therapeutic experiences, not only of patients and clients, but also of us as the clinicians. Despite this strong increase in the quality of the therapeutic experience, some estimates say that less than 20% of behavioral health clinicians actually use measurement-based care as part of their routine standard practice. And this can be due to a variety of reasons. This is certainly a non-exhaustive list of the barriers that might come up when we're talking about what it means to actually implement measurement-based care. Some of them including clinician buy-in to these programs, as well as clinician training, knowing not only how to administer and collect these data, but also how to talk about them with families in a way that is relevant, helpful for the therapeutic process. Concern on the family side about confidentiality, about the way these data will be used in the long run. Low completion rates. Again, this is something that I'll touch on here with this particular population. And competing requirements for us as healthcare professionals. We have a lot of things we're trying to accomplish in a short time that we have families sitting in front of us. It can be really difficult to balance all of those different demands and all the ways we want to spend our time, all the things we want to touch on with these families. So this is a non-exhaustive list of some of the parent behavior management training programs that we have going on in our behavior and attention management program. And this is an example or a visualization of some of the stepped care model work that we're doing. Again, I'm going to be focusing on our Disruptive Behavior Crisis Clinic here today. I think this is a really interesting program to talk about measurement-based care with in particular for a number of reasons. The first one is all these programs are delivered only via telehealth at this time. So this is a great way to increase the reach of these programs for families that are in low resource communities, are outside of the greater Seattle area, or otherwise wouldn't be able to take the time to travel to a physical location due to work or other commitments. And also because our DBCC program is designed for families who are in crisis right now. Many of our referrals come from the emergency department, from families who have presented there due to the severity of the disruptive behaviors and challenging behaviors that are occurring in the home, typically using caregiver restraint or physical punishment as response to these behaviors. And these are families we really want to get in and provide support as quickly as possible. And these are also caregivers who have typically their own mental and physical health diagnoses and their own histories of trauma, lots and lots of complicating factors with these particular families. So I think this is a really interesting place to explore measurement-based care with families who are enormously impacted and enormously stressed when they come to us for this program. So we have pre and post measures that are disseminated to families both before and after the program. You can see the names of those measures there. They include questions about caregiver strain, as well as the severity of the disruptive behavior that the family is experiencing. And obviously post only, we're also sending out a satisfaction questionnaire. We're also asking families to weekly complete some questions about the child's behavior, as well as the caregiver's own skill use of what we're talking about during these sessions. And these items are like very idiosyncratic to our program. We are asking them exactly about the skills we are teaching and talking about during the program, as well as the behaviors that we're hoping to see change in response. So the child behavior questions are focused on duration, frequency, and intensity of escalations, as well as any instances of caregiver restraint that have happened in the prior week. week, and then parent skill use, not only the instances when there's an opportunity to use these skills, but also parents' confidence in their ability to use these skills outside of session. So one of the ways that we're working on trying to visualize these data, this is just pre and post. Like I mentioned, the surveys are distributed weekly to families electronically through REDCap, and then that data is imported into Tableau for us to take a look at. And we also get automated emails every Monday morning, right before we jump on with these families, that show us these graphs, and we're able to take a look and see what families have reported to us as far as the prior week. So this is aggregated data across all of the families who have completed both their pre and post measures in the last 2 years. So it's about 169 families in total. These data capture about 80 families who, again, completed both pre and post measures. I think this is really interesting and helpful. We can see really modest reductions across a lot of these things, which is encouraging. But this is a helpful way from a program evaluation standpoint, looking at that pre and post data in Tableau for us to take a look at. This is an example of our test record. So this is what I might see if I opened my Tableau, navigated to one of my patients, and was taking a look at those, again, those child behavior questions that we ask families to complete on a weekly basis. And so I might take a look at this and see, oh, great, we're reporting, we're down a few minutes for our fire intensity duration as we're going on through this program. We can also take these weekly data and generate some trend analyses as well. So these are just 2 examples of some of the questions we ask families. So duration of the escalations, these are real data. Families in general, on average, are reporting a reduction from about 90-minute escalations with their children to about 33 minutes, which is a really encouraging statistic. And also, flowers and weeds is our term for the clinical skill of praise and ignoring. And so this is the number of instances in which caregivers are using clinical praise and ignoring to respond to provocative behaviors specifically. And so caregivers are reporting that at the beginning, about 34% of the time they're trying to use praise and ignoring. And by the end of the program, about 66% of the time, we're seeing that increase. And then something else that I haven't mentioned yet is this is not meant to be a program where we get families in, we send them on their way, and we hope they're good to go. We refer pretty much all of our families onto an additional program. Again, the purpose of this program is just to get families started, get them hooked into some of these supports, and then refer them onto something more to continue working on these strategies. So this is encouraging that we're able to make a dent in the use of some of these evidence-based skills outside of session and in the home. We are not immune to a lot of the barriers to measurement-based care in this program, as you've probably already picked up on. Completion is a really, really challenging issue and not at all a surprise for this population. These families are enormously stressed, and there's a high rate of distress in trying to deal with these problem behaviors, as well as caregiver challenges and trying to balance all these demands of daily life while trying to parent some pretty challenging kids. So completion of measures is one barrier that we're definitely facing. And another one, like I mentioned, is competing clinician needs. We have typically 4 sessions with these families that are 90 minutes each, and we are trying our best to stabilize so that they are able to make it to the next thing as safely and effectively as possible. And so we are often finding ourselves trying to balance how we're going to allot that time for the best outcome for that family sitting in front of us on a weekly basis. So some of the strategies we might be able to use to try to support and address these barriers include greater engagement in sessions with data. And I think that this also goes hand in hand with training our clinical team on how to talk about these measures with our families and integrating it more fully into our standard clinical practice during this program. I think one of the other benefits of having greater engagement with data in this program is also going to be that these families are often finding themselves in a really hopeless place. This is a theme. We find families coming to us saying, I just feel like this is never going to change. But being able to say, hey, take a look. In week 1, you reported that your child's behavior was like a 90 out of 100 in terms of intensity. And this week you're reporting it's a 55, right? Like that's really encouraging it, being able to show that visually. So finding ways to better engage with these data during session. So some final takeaways just to think about. Barriers can definitely be engaged with and reduced, even among these really highly impacted populations who are enormously stressed and have a lot of competing demands in terms of childcare. We can also leverage our technology to automate distributing these measures, analyze these measures, and visualize these measures so that we're not having to do that legwork. We can literally click on that graph when we log on Monday morning and it's ready to go and to use for session. And then finally, robust measurement-based care is really an integral part of high-quality, evidence-based mental and behavioral health treatment. And the data collected using MBC is important not only for the individual treatment for the family sitting in front of us, but also for ongoing program development, implementation, evaluation, and research pursuits as well. Thank you guys so much. I will now, yes, you can clap. And finally, last but certainly not least, I'd like to introduce Dr. Sheena Friesen.
Morning, everyone. I am really excited to talk with you all about the implementation of modified positive behavior interventions and supports on a pediatric inpatient psychiatric unit, or the PMU, as part of a large quality improvement project that I've been so fortunate to be a part of. So first, before I get going, I, of course, want to extend my deepest gratitude and appreciation for Dr. Alicia Thompson, who is the clinical director of the PBMU, one of my supervisors, and really just the visionary and leader of this huge model of care change, in addition to the PBMU leadership and psychology team members, clinicians, staff, and patients. So I'll start by addressing our problem area. Of course, on an inpatient psychiatric unit, that is the practice and use of violent restraints. We know that about 1/3 of every patient who comes to an inpatient unit has one violent restraint per encounter. And this is problematic, it's traumatic, it can potentially lead to death. And the use of violent restraints disproportionately affects neurodivergent, non-white patients, as well as patients with histories of trauma. And most remarkably, Black patients are specifically at the highest risk of receiving violent restraints compared to their peers. On the flip side, many restraints can be avoided. We know this in the research and the data, yet not practicing restraints at all could also lead to risk and safety concerns. So our question that we're left with is, how do we practice the least restrictive intervention and maximize safety for our patients? So one potential answer is implementing a modified positive behavior intervention and support framework. This framework is borrowed from educational psychology, where we're taking a public health approach and using the least restrictive intervention to support a kid's needs. This is informed by social learning theory, applied behavior analysis. For those of you who are very familiar with parent management training, similar pyramids have been used as well. When we know that when we're loading upfront positive behavior interventions, that most kids' needs are met with this tier 1 level of intervention, and we're ameliorating the need for more restrictive interventions like restraints. Thanks for bearing with me with the slide disorganization. So we have some emerging evidence to show that when PBIS, again, originally taken from schools, it's been implemented in tens of thousands of schools now across the nation, has been modified now for acute treatment contexts. And there's some really promising research. Our colleagues at Hopkins have shown a remarkable reduction in restraints, the duration of these restraints, and use of PRN for agitation and aggression as well when modifying PBIS and implementing this on their inpatient unit. They also had similar findings in their PHB step-down context as well. This still doesn't speak to, okay, what do we do about disproportionality? That's great that our use of violent restraints decreased, but what about decreasing how this is impacting particularly our Black patients and our patients of color in general? There's a paucity of research on what to do when addressing disproportionality of restraint use on inpatient units. So we do have some research that shows that when PBIS is implemented specifically with an equity-focused lens, that we see statistically insignificant, in a good way, differences in discipline rates by racial group. And what equity-focused lens specifically looks like is data-based decision-making, where we're disaggregating data and routinely analyzing that data when it comes to coercive discipline measures, in our case, violent restraints. Embedded anti-bias training when teaching to a PBIS model, and explicit instruction of behavioral expectations. What exactly does it look like to be safe, respectful, and to communicate effectively during this particular task or activity? So on the PBMU, we have rolled out a gargantuan model of change, and this is our theory of improvement. And I want to highlight a few components of this big model of change that I've been so fortunate to be a part of. Our aims, of course, are to reduce violent restraints by 10%. And I should add, it should also read decrease or ameliorate the disproportionality that is true on our unit and across inpatient units around the nation, and to achieve a 5-to-1 ratio of positive to negative interactions. And that's kind of our proxy of how are we doing in really implementing those tier 1 level interventions of praise, positive reinforcement, teaching expectations, et cetera. Our primary drivers are to then build and implement a multi-tiered systems of support or a modified positive behavior intervention and support framework, and to boost staff resources that help our team do so. So specifically, our secondary drivers are then building out a tier 1 intervention or prevention framework, beefing up our tier 2 and tier 3 interventions, enhancing training resources to teach our team of more than 200 folks to this new model of care, and enhancing our multidisciplinary collaboration. Some specific intervention components that I really want to highlight include that are novel now to the PBMU would be a token economy, providing our patients opportunities to receive stamps, positive reinforcement that can then be cashed in for experiences and prizes, acknowledging their hard work for meeting expectations, the design and utilization of a behavior matrix that spells out exactly what does it look like to be safe, responsible, and to communicate during a particular activity or context or interaction. The use of and deployment of super users who are floor staff that we have trained and have been in part of our model of care design, and then have been peer modeling and providing guidance and feedback to their colleagues while working with patients on the floor. And a huge gift that I think is just hard to come by is we've been able to and been really fortunate to provide upwards of 40 hours of training led by psychologists and educators to train our entire 250 plus team, an army of folks that really support our patients on the PBMU to this new model of care to ensure that we are really doing this to fidelity and well. So I want to highlight a little bit of our data. Our go live was early March, so we're still in our initial early implementation phase. Pre-MPBIS implementation, we saw that our overall mean percent of patients with one or more violent restraints was about 33%, and the number of violent restraints per patient day was 0.26. We see that Hispanic, Black, African-American, Asian patients, as well as folks whose race and ethnicity are unknown, were above the mean in both of those measures prior to our model of care rollout. And post-model of care rollout, now in this early phase, we see that those averages have gone down. At the same time, you'll notice that our overall mean number of violent restraints per patient day, both measures have actually increased overall, and we're still in this early implementation phase. And so I'm really curious to see what this data will look like over time when it's not particularly driven by a particular patient that we have that's really informing our data at this time. I'm trying to see if there's anything else that I want to highlight before I switch to the next slide, or it switches for me. Okay. So next we have our PRN for anxiety and agitation discrepancies that I want to quickly go over. You can see that our group mean has increased post our model of care rollout at this time, and patients who've endorsed two or more races in general have a remarkably higher use of PRNs for agitation and aggression. So I will go over some future directions. We're in the process right now of collecting fidelity data, completing 10-minute observations, behavioral observations of how are folks doing in practicing that 5-to-1 ratio, timely delivery of stamps that is paired with specific labeled praise. And we're collecting that data on the patient level so that we can also evaluate if there's any disparities in how our bias might be impacting who gets praised and stamps and so forth. Of course, we want to assess our adherence then to our model of care, and then we want to analyze differences in that 5-to-1 ratio and in our practice of violent restraints across and within racial groups. We are in the process also of launching booster trainings to attenuate drift from fidelity. So this past month, we've been uploading videos, brief training videos, and PowerPoint presentations on GROW that are modules and that are required of our staff to complete to help us, again, practice this new model of care to fidelity. So that's all I have for you today, and I'm going to turn it over to Dr. Kuhn to moderate questions. Thank you, everyone.
We have one question in the chat so far from Frida. This question is for Shannon. Have you all had the chance to look at the data in terms of responders versus non-responders beyond average pre-post data? Frida finds it hard to believe that pre-post changes are so moderate. No pressure.
Yes, we have not taken a look specifically at responders versus non-responders. I'll also say folks that didn't complete the pre-version are also not likely to complete the post version, unsurprisingly. So the data that I showed in the dashboard is really focused on just pre and post. And it does definitely look like the changes are moderate, but again, the sample size is like decent. It's about 169 in total, and then about 80 families in total there. The other thing to remember is that these are scored rating scales. So these are like post-scored. If we were to pull out a few individual items and take a look there, we might be able to see a more like visually robust difference from pre to post, because we know that those fully scored measures are not always as responsive to change over time when we're looking at intervention, response to intervention. So definitely a great future direction to continue to dig on those characteristics of responders versus non-responders. Absolutely.
Great. We can also take questions in the room. And I just want to comment on like what an impressive group this is and how much change is being led and co-led by our postdoc trainees and how exciting that is.
Well, I want to echo that. Really interesting, fascinating presentations and so much cool stuff just to think about how we roll that into care here too. So I was really torn about who to ask a question, but I'm going to ask Angela a question about the online or the app training and how much coaching the people in the intervention group got, and what do you think the impact of sort of coaching or sort of active involvement of a human with the app itself? You know, where could that be leveraged, or was it already?
Yeah, so I briefly mentioned they did have an hour and a half to 2 hour telehealth consultation before they were randomized. And so I think that definitely impacted it because, we also saw in the control condition who also were exposed to that consultation session still showed some improvement. So I think because it was it was one-on-one. So they kind of had we were going through the details of, these are how to, use these prevention strategies and how can we adapt it to that specific behavior problem that you're focusing on for your child, whether it's tantrums or what have it. So I think that definitely helped. But some of the feedback from the parents I think we could implement is, just checking in every week. So like each week was really focused on one theme. So the first week was just behavior principles. The second week was prevention strategies, reinforcement, generalization, and maintenance. So I think having that maybe check in at the end of each week of like, how did it go? What questions do you have? I think like the limitations with the app and the limited funding I was able to get was that there wasn't a lot of ability to interact with the parents through the app, and it was all again through that company. So I'd hope that with more funding and we'd be able to implement more of like that kind of interaction even through the app if possible too, to answer any questions or troubleshoot.
I just want to echo Larry and Carol's point, just how impressive you all are, and the kind of future directions that we can see for our field and for our department. It's really exciting. My question is for the three of our autism-focused researchers. So you all talked about interventions, right, that have been implemented in your research, and all of them use evidence-based principles that many of us in the field of mental health have either been trained in or have heard of. And yet one of the consistent barriers we hear, as you brought up, Alana, is that patients in the community and families in the community are often excluded because of their diagnosis of autism. And for youth, this is for adults. And I think some of our job as autism-focused kind of mental health providers is to help with that and decrease that barrier. So I'm hoping to hear from maybe little tidbits from each of you about easy modifications that you might make in either through your research intervention or through clinical work that you do with the autistic community for modifying just a little bit the evidence-based principles that we all are trained in in our field. Big question, sorry.
Yeah, no, I think that's a really important piece. And because of the underexplored nature of including autistic people, especially with varying presentations and research, it feels like like a chicken and an egg thing, where we have something that we want to do, but we don't know how to do it with a particular presentation. And so I think as a field, we have to take a few steps back and stop trying to intervene before we know the information that's going to be relevant for adapting interventions for this population. And so I've mentioned that for Selfie, I want to bring it down from adults to adolescents, but then one of my challenges is that I don't really know much about how autistic youth are using the internet. And so we also want to adapt it for adults with intellectual disability. And we're like, well, we don't really know how this population also uses the internet. And so instead of just bringing Selfie into these populations or bringing whatever evidence-based practices to, adapt it, we're doing a needs assessment first and figuring out what do you need and what are the interventions that might be most appropriate for your needs before we tell you, provide you with a specific intervention. So I think we need more engagement with the community before we proceed with intervention. We tend to be really fast in psychology.
Thank you so much for this question, Jen. I have two things that I want to say. So one of them, in thinking about DBT in particular, one of the things that the autistic adults that I've been speaking with have talked about is for providers to really understand the behaviors that may be specific to autistic folks, in particular thinking about dysregulation. So my participants have spoken about meltdowns, shutdowns, autistic burnout, and making sure that clinicians are familiar with those experiences of autistic people and how those might differ from a suicidal crisis. So that's one. And then in terms of kind of concrete strategies, I actually wrote a paper about this a couple of years ago and just provided a couple of ideas for providers. But some of them are, really structuring sessions and using visuals and more concrete strategies in sessions so that patients understand what's going to happen and have some say in that as well. Many autistic adults in particular have also asked for longer sessions or some flexibility in the length of sessions. So sometimes they need a little bit more time, and sometimes actually a short check-in is all that they need. So being able to offer some of that flexibility, and then also providing visuals can be really helpful for many of our patients. And of course, none of these are blanket recommendations, but just options for considering adaptations in mental health practice.
I think I'll kind of echo what both of Anthony and Alana said. I think with my research, a lot of the parents, again, really have very specific behaviors that their child is exhibiting. And, we say in the field, you one individual with autism, you meet one individual with autism because they present so differently. And so with the app itself, I think what would have been great is having it modified. So if they, selected, okay, the behavior I want to focus on is tantrums, and then the strategies that, as they go through the app, would focus on how to apply it to that specific behavior, which is why we kind of had to have that consultation session to really talk it out with them. But again, it was rare, and we were glad that we were able to carve out like 2 hours to meet with a parent and talk about it. But that's not always feasible to for them to have that time, and so it would be nice to be able to adapt that through the app and see how to cater it to the specific behaviors that they want to focus on.
This was going to be just a question for Alana, and I agree, everyone did a fantastic job, but it might be a broader question. It's about sort of whether you're engaged in a intervention redesign process or a new intervention development process, and the sort of constant pull toward scope creep and sort of doing more and more. And my question for Alana was going to be, what sort of things did you decide, whether they were usability issues that came up or things that people sort of talked about wanting or that came out of that process? Did you just decide, weren't necessarily addressable or it wasn't feasible to have them addressed in sort of a new iteration of the intervention? But I think it could also be applied, or could be a valid question when building something from the ground up, because we always, like every time we engage in a sort of partnered information gathering process, there's always more that comes up than you could possibly sort of address or incorporate. And there's always that pull toward scope creep. But at the same time, the more scope creep you get, the less implementable any intervention becomes.
I'm happy to respond to that. Thank you for the question, Erin. So I'm actually going to pull from some really recent data. So as part of the second phase, I'm actually going to hand up if that's okay. As part of the second phase of the project that I'm conducting, we did demonstration studies with groups of autistic adults where we gave them the DBT materials a few weeks in advance, and then we met with them as a group, presented on DBT, and then solicited their feedback about each of the stages. So this is that second part of the discover phase, which I did not include in my presentation because we just did it like last week. So one of the things though that one of the autistic adults asked for was a support group or kind of a process group. And that is something that we had a conversation about with my project collaborators kind of right after, like, would that be something that we could even consider adding to comprehensive DBT? And so that's something that may be kind of outside of the scope of the redesign. That just might be kind of a low-hanging fruit example to give to you because we haven't analyzed those data completely yet, but that's one example. Thank you.
Do any of the other postdocs want to comment?
I can go. I think when it comes to, I'm in a unique position because I'm developing a new intervention, and I think that provides a lot of flexibility to where established interventions might have some challenge. I think one of the unique kind of things that might be more of a necessary thing is that I intended this intervention to be really strengths-based. I came from a very neuroaffirmative lens, and I wanted to see the strength in using social media for developing relationships. But I know that also comes from my neurotypical lens and success on social media. And I've learned from, being more immersed with providers and parents that internet safety is probably the biggest concern. And so I know that if I want this to be a clinical service, something that could be billable, that it does have to have that mental health component. It does have to be clinical, and I do have to use, relevant clinical outcome measures. And so that's something that I'm learning as I'm getting more clinical experience, is that you have to balance the demands of neurodiversity, being neuroaffirmative, but then also, the state of medicine and science.
All right. Well, we are out of time, and I want to really thank all of our presenters and their mentors, and just say what a great way this is to end our Grand Round series on such a high note of all the positive changes that you are making and will make in the future in our field. Thank you.